the most beneficial for you?
I think the most beneficial was just realizing that I had to look at it honestly. Of like,
Bing, 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 bing.
So I had to be finally honest with myself.
Yeah.
Of like, instead of being in denial of like, this isn't a problem. Like, everybody does it. Like,
Yeah.
and I finally just had to be honest and like, I'm taking it too far. I'm not casual drinking with friends, and so I really had to look at why was I filling the void. Nathan Klotz, and I'm a therapist here in Colorado Springs. I got my master's degree in clinical mental health counseling, and really have wanted to specialize in trauma, substance use disorder, as well as focus a lot on just like a little bit of like personality disorders as well with cluster B.
Yeah. All the hard stuff.
All the hard stuff, yeah.
Is that like your personality? You go for what is really difficult to treat?
Yes.
And you have a passion for that?
I do have a passion for that.
Yeah.
And I think it's just that I see a lot of that in also the community. So we have veterans here. We also have just overall like substance abuse affects everybody throughout the U.S. So
Yeah.
just really wanting to give back. And I mean, I've had my own like experiences before getting into therapy. So I know
Would you
a little
be willing
bit.
to share that? A little
Sure.
bit about that?
So in my 20s, you know, is the typical like party time. So I think everybody has that like when they go into college. But as I got older, it started to get a little bit more as I wasn't able to really find myself. And so I looked to coping mechanisms such as alcohol. And it just kind of increased over time.
Yeah. What was the
and
aha moment that you knew, hey, I need to do something about this?
My aha moment was actually when I got a TUI. So, so I was one of the, you know, many that did not want to change until I needed to change. So once I had been processed and gone through the court system, I just decided that I wanted to change. And so I really got into more of the communities. I did a little bit of AA, but I just also wanted to really kind of get better. And I saw how the alcohol classes were and got really interested in wanting to do that as a profession.
Okay,
really,
the classes that you were required to take,
Yep.
you mean? Okay.
So I really wanted to get into the field. So I started looking at how to go about that. So I went and got my master's, and now I'm working on LPC, but I've thought of also being a addictions counselor as well, because I know that's important for the community.
What was the most helpful part of your healing? You talked about the classes that you were required to take, but what, in that whole journey of healing, what was the most beneficial for you?
I think the most beneficial was just realizing that I had to look at it honestly. Of like,
Bing, 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 bing.
So I had to be finally honest with myself.
Yeah.
Of like, instead of being in denial of like, this isn't a problem. Like, everybody does it. Like, and I finally just had to be honest and like, I'm taking it too far. I'm not casual drinking with friends, and so I really had to look at why was I filling the void, and really get down to what is it inside me that I'm trying to escape from or fill.
Right.
So.
Right. That's some deep work.
Yeah.
And do you think that's harder for men?
I think it is sometimes a little bit harder for men. I know it can be hard for women just in the sense that they don't always want to talk about those things as well.
Mm-hmm.
But I think men tend to just hide their emotions a lot. So they don't talk about it as often, or they just joke around instead of really talking about the deep stuff.
Yeah. And you were able, just in this, few minutes of knowing me, were able to be authentic, genuine. I really respect that. And the viewers, that's what they need to hear as well. What would you say to someone who is watching that maybe is starting to get that nudge on the shoulder that something might be a problem?
I would say that to just look at it honestly and look at really how much are you drinking, and look at, is it something that you're using to cope with? Because I think a lot of times with heavy drinking, which actually is only considered 15 or more drinks a week. So
yeah. And people need to know that binge drinking is more than 4. So
I think when you look at that, I could have done 15 drinks in one night. So looking at that and being honest with yourself of like, I'm taking it way more than I should be. Or how many times am I blacking out? And how many times am I not being present for those moments that are important, like family?
Talking about family, what would you say to a family member that may be watching that knows someone has a problem, has maybe tried to approach it? What could a family member do or not do if they think their loved one has a problem?
I think with family members, it's important to remember that the addiction is a little bit different than the person. So the family members tend to want to fix it and solve it and do everything for them. And it's kind of having to take that step back and realize that you don't want to just like rush in and try to solve everything. So it's more of like planting like little seeds, and hopefully that they're willing to come and meet you in the middle. And it's also important to realize that you're powerless over the addiction itself. So whether you're the person in the addiction or whether you're the family member. So having to be able to give resources, but allow them to take their own steps. And also just in the sense of maybe try to not enable if possible. Not to say to help them out when you can, but I know some people will use that to their advantage. Of if you give them cash, then they're going to use it for something else. So,
one of my favorite books on addiction is The Biology of Addiction, Why It's Not a Disease, I think is the title. And it's written by a neurobiologist that talks about kind of separating addiction. And you said this in the very beginning, kind of separating the addiction from the person. And trauma, which I know you specialize in trauma as a professional. Talk about how, trauma is kind of that gateway for many people, not everybody, but, for many people.
It can be a gateway, just in the sense that when you have trauma, you can have that aspect of how do I cope with it. Such as like veterans that get PTSD, they may look to substances to be able to sleep or be able to kind of get past a lot of that. Not to say that's not very like healthy, but
but it works. That's the problem.
But it works.
And that's why it becomes an addiction, because it works. And we talk about professionally like maladaptive coping.
Yeah.
It's not that it doesn't work. That's the problem. It works, but it's not good for you. And it goes down, it creates another problem.
Yep. And addiction kind of just shuts off a lot of those cognitive aspects. And so it's able to kind of bypass.
Yeah.
And with trauma, you have just all these things adding onto it of the hippocampus might be affected to where your memory's not as good. Your amygdala might be firing a lot more, so your fear response is constantly going. And so...
And alcohol decreases, it's a CNS depressant.
Yep.
So it's, it actually is chemically somewhat treating that, not in a healthy way, but we can see how it's easy to go down that path.
And it's easy to go down that path. That's why anxiety and depression and substance use disorder are very co-occurring disorders within substance use and PTSD.
Yeah.
And so it's really looking at that of like, how can we look at other adaptive behaviors that are better? So.
Yeah. One of the things that I talk about in the Mentally Strong Method is, we don't like to admit it, but there's things from our childhood that are still impacting us. And so when we do thought maps, we ask, when did you feel like this as a child? How does this impact your spiritual relationship? Kind of questions that people don't often think to ask themselves. They're thinking in the moment, what I'm anxious about right now or depressed about right now. But when we get to the power of choice, we actually have them organized. And addiction is its own category. Trauma is its own category. Grief is its own category. Negative self-talk. And then behaviors and choices, right? Because everyone says, oh, your substance use is a choice. Well, the act at that moment might be a choice. But the complexity around everything, including trauma and grief and negative self-talk and the neurobiology that's happening in addiction, those are all separate things that we need to do something different about, right? Our negative self-talk, we should try to talk positive, but that doesn't actually help our trauma.
Sure.
So tell me, I know you specialize in trauma. Talk about the specialty treatments that you do for trauma.
So for trauma, I usually use EMDR, which is eye movement desensitization and reprocessing. So that's working on using the bilateral stimulation, where we're trying to get the nervous system to go into a specific one, whether it's parasympathetic or sympathetic. So if we want to be able to keep them calm, we'll do slow, just to get them into the parasympathetic. If we want to get them into reprocessing, then we go fast to get them into that sympathetic.
So talk about the reprocessing. And this is where you would actually have someone try to go back to a specific event?
Yes.
Tell us a little bit about that.
So once we kind of get a good history and get them prepared for EMDR, then we're going to assess the specific target that they want to work on. And then we're going to go into desensitization.
Okay.
So we want to go fast to be able to bring them into reprocessing, and hopefully their adaptive neural network will kick on.
Okay.
And bring in a more positive to the memory.
Okay. How long does it take you in counseling somebody to get to the point where you're ready to do some of that reprocessing?
Usually you want to kind of get a good understanding, so like a few weeks.
Okay.
You want to kind of get a good understanding of what their history is for their trauma. You want to get them prepared a little bit by giving them some coping aspects with the slow processing, so that way they can, if they get triggered, they can use slow bilateral for calming. Or you can use different mindfulness techniques of kind of bringing them back down, or they can kind of take their trigger and then put it into a box, so that way they don't have to process it right then.
Yeah.
And then once we get them a little bit more stable, since we want to make sure that they're not in any type of crisis when we do this. Then we start doing the EMDR, and that's when we can desensitize, hopefully instill a new belief, and then get them to release it from their body as well.
And how many sessions does it typically take to do? Let's just assume somebody has one isolated traumatic event, which in reality that's usually not the case, but let's say they have one really specific traumatic event that they're trying to work through. How long would that take?
If it's one specific event, sometimes you can do that within like a few weeks.
Okay.
Just in the sense, there's some protocols as well for. It's not necessarily EMDR, but it's similar, where you're doing trauma work of getting them to re-talk about the situation and then bringing them back down to calm, so that way they can process it smoothly and build up that resilience to it. So you can use EMDR also with that, of just do a few sessions, and hopefully the desensitization will come down, and we can get them to instill a new positive belief.
Now, the reality is, especially people with substance abuse and complex trauma, how do you begin to gently open up that Pandora's box, if for lack of a better word?
Sure. So depending on the client, if it's not complex, then we can kind of go into some of those deeper memories sooner.
Okay.
If it's complex, then sometimes we want to go slow and really kind of take our time, so that way we're not getting them into a crisis situation.
Right. And I can tell you from a medication provider, this is what happens. So we get somebody, we refer them for EMDR, and the box has been open and they can't get things, and then they need an adjustment in medication just to stabilize. So what would you say to someone who is ready to start that journey of EMDR but has complex trauma, like the expectations of time, weekly time commitment? Because people want a quick fix, but if you've got 5 years of trauma consistently, it's not going to even be done in 5 weeks, right? I mean, it's it could take 2 to 3 years.
I would say with the complex trauma, you can see some changes within the first couple months, but to get to the lasting stuff, it could take a few months, like to a year. Okay. Because
that's better than my expectation, so that's good.
Depending on, I would say it's similar to ART, which is another one that kind of works within different bilateral, and being able to really process and bring things back down.
Okay, tell us a little bit more about ART.
ART is more newer, and it's more focused on trying to get accelerated.
Oh,
so,
okay.
I'm not sure kind of on the full aspects on it.
Okay, are you planning to get trained in that?
I was looking into it since I've heard many people talk about it now. Okay. So it's a newer one, but I've heard good things from some people with complex trauma, that it works just as well as EMDR. Okay. So you can look at
we do a little bit of brain spotting here. I'm not sure if you're familiar with brain spotting. Yeah. Everyone claims to, be just as good as EMDR, but EMDR is what really has that scientific backing and research behind it.
Yes.
Do you know anything about brain spotting?
I know a little bit about brain spotting as well. So I know with brain spotting and ART that it's similar in that you're looking to find where the triggers are and desensitize them.
Yeah. And maybe quicker. Okay.
And so I would say for complex, you're looking probably closer to a year. Just in the sense that if it's multiple, like over a childhood period, then there can be a lot to look at.
Right.
If we're going to target specific memories in each session, then it can take a couple weeks per memory, and then working through that. And I will say that just it kind of depends a little bit on the person too.
Okay.
Some brains are a little bit more adaptive than others, and so not to say that's a bad thing.
Yeah.
It's just
and whether they've chosen sobriety, right? Like it's
yes,
that all kind of gets intermingled and those kinds of things. So we talked about substance abuse, trauma, and your other specialty, personality disorders.
yes,
Not my favorite, mostly because as a medication provider,
Yes.
There's no treatment, right?
Yeah.
You know, it's sometimes I feel like it's a cop-out, like, you know, oh, this person has borderline, so therefore I can't treat this emotional dysregulation.
Sure.
And I always kind of challenge that from a medication perspective. But tell our audience a little bit about what are personality disorders and how does a licensed counselor treat that?
So there's a few different clusters of personality disorders. Some people know cluster A, schizophrenia, and then cluster B, people are starting to use it more and more, but not necessarily in the correct terms.
I agree.
In cluster B, you have narcissism, borderline personality disorder, you have the histrionic, and then I always forget the last one.
The antisocial.
The antisocial, yeah. Sorry.
Which people always misuse because
Yes.
An antisocial personality disorder is more like a sociopath, right?
Yes.
That they don't have remorse. Whereas if you just don't like to go outside, that's a different thing.
Yeah. So with those, that's kind of the cluster that I focus on. And then you can also have, from the other cluster C, the obsessive compulsive personality disorder, and kind of a little bit more of kind of neuroticism in those. Now, schizophrenia, most people know that one's really hard to treat. That usually needs inpatient, just because...
Needs medication. Needs me.
Yeah, they need medication.
Yeah.
They need lots of therapy because they need to work on the delusions and trying to get closer to reality with the hallucinations.
Yeah.
Cluster B, people kind of know a little bit more about in the sense that it's becoming trending words.
Right.
So people like to use the word narcissistic. But narcissism in general just means this hyperinflated ego, but low self-esteem, because they're secretly insecure. They just use the control of other people to get that inflated ego.
Yeah.
And then histrionic is kind of really kind of like seen as like almost like a sex object in a word, because they really love attention. And they don't mind getting used for it. And then antisocial is like, I'm going to burn the whole entire world down. I don't care about rules.
Right.
And I like to lie constantly.
Yeah.
And then borderline personality disorder, which I've worked with, is more of the issues with mood. So it can look like bipolar. It's just they don't have the waves like bipolar. It's more of like back and forth between the moods. And they can have substance use disorder a lot because they have issues with impulse. So it can look at binge eating, excessive shopping, excessive use of substances, like enjoying to be a race car driver. So that constant like enjoyment of risk, but deep down it's an abandonment wound.
Yeah.
Because their fear is that people will abandon them. So these moods come and go, but can last days, and it's just that they have so much troubles with the interpersonal as well.
So what do you use for treating personality disorders?
For treating personality disorders, we want to kind of look at possibly using something like DBT.
Explain that to the audience.
DBT is dialectical behavior therapy, and it looks at mindfulness, distress tolerance, interpersonal effectiveness, and then also working with emotional regulation.
I like to call DBT like CBT on steroids.
Yes. So it is derived from CBT. They added mindfulness to it. So there is kind of a little bit of like a Buddhist kind of way in it, and because it's looking at getting acceptance and going from change. So you're trying to change the way your emotions regulate and change your interpersonal effectiveness with others. And then you're trying to accept more distress and mindfulness into your daily life. Because it's kind of getting more into the present instead of like letting the past and the future control your emotions. So
Exciting.
Yeah.
You're doing some really good work.
Yeah.
Thank you so much. Tell us a little bit about your current practice and your vision for your practice.
My current practice is kind of just expanding and really trying to get into really helping those in my community. So I really want to help those with addiction or personality disorders, and
I'll be sending you referrals for
kind
sure.
of to also really work with PTSD. So I know we have veterans here that have possibly all of those. And so really working to help the community to get better. And I know it can also affect also suicide as well. So because sometimes when people are deep in it, they don't know any other way out. So
Yeah. What is your personal vision for, your practice, your business?
my personal vision is to just really build my practice. Eventually, down the road, I'd like to build it into something a little bit bigger, and have possibly my own interns or my own pre-licensed people that want to be able to help as well.
Yeah.
And so I really want to build the private practice and get to being able to really be a facility that cares about Colorado Springs.
Perfect. Well, we will put your information in the description below.
Sure.
Is there anything else you want to share with the audience?
I think just to share that with everything out there, there's close to 10 million people with substance use disorder. There's close to 10 million people with PTSD. And so it is about 6% of America that struggle with this. And so I think we just need more and more awareness around it and being able to really help people find their resources.
Perfect. Well, thank you very much.